So look, often we find HCCs on ultrasound scans, and we find them on ultrasound scans because people are being screened for HCC, so the cirrhotic population in particular. So they tend to get a 6-monthly surveillance ultrasound scan, and virtually all cirrhotics are now on one of these surveillance programs, as well as a few other categories, so non-cirrhotic patients with hepatitis B, those with hepatitis C and fibrosis in some centres, and those with NAFLD and fibrosis in some centres. And ultrasound is, of course, as we all know, operator and patient dependent. So in the best centres, HCCs get found with about an 80% sensitivity in the surveillance population, but in most real-world scenarios, it's more like about 65%. And of course, if you then look specifically at patients who are very difficult to ultrasound, for instance, those with large BMIs and those with NASH cirrhosis, for instance, then the sensitivity can be significantly lower. So ultrasound surveillance is not perfect. What's a positive surveillance ultrasound? Well, basically, if you find a solid nodule of 1 centimetre in diameter or greater, it can be hypoechoic or hyperechoic. HCC can be either. And if you find that, then that triggers further imaging with multi-phase CT or MRI scan. If the lesion on ultrasound is less than 1 centimetre, then you just repeat the ultrasound at 3 months. You do not need to do a CT or an MRI scan. You just continue doing ultrasounds until it grows and gets to 1 centimetre, or if it disappears, you then go back to 6-monthly ultrasounds. And here's a typical, slightly inhomogeneous nodule in a cirrhotic patient detected at screening.